Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with a Doctor. If you haven't been with us before, this is a show where we interview physicians, local physicians, about their craft and about their specialty. And in doing so, we learn quite a bit, and you will learn quite a bit too. I keep saying this evening, but it's not evening. It could be any time of day right now, but it is day. We have with us Ramy Fahim. He is a local podiatric surgeon, a foot and ankle surgeon with Family Foot and Leg Center. And we're here to learn about diabetic foot today. Is that right?
Thank you for having me, Dr. Lee. Yes, indeed, we'll be discussing a little bit about diabetic feet and management of diabetic feet as well, too.
Can you tell us a little bit about your background and yourself?
Yes, sir. I originally from Toronto, Canada. I went to school in Cleveland, Ohio. I did my residency training also locally in Cleveland, Ohio for 3 years, and then I pursued a fellowship, extra fellowship year of training in Youngstown, Ohio as well, and been in practice here with Family Foot and Leg Center for the last 2 years, going on my third year next summer, and it's been fantastic so far.
Well, welcome back. We did this show once before with you, and we learned a lot at that time. So it sounds like you migrated from north to north, and you kept coming, and now you can't go any farther south unless you
That's exactly right.
go to Cuba.
I took the 75 and never looked back.
Well, tell us a little bit about where your practice is located, and if you have partners. And
Yes, currently I practice, it's a group practice. Myself and two other physicians, Dr. Kevin Lamb and Dr. Drew Chapman. We have 3 locations locally here in Naples. My office happens to be in North Naples, right across the street from North Collier Hospital. Kevin Lamb's office is downtown on Goodlet Frank Road, Goodlet Frank and Golden Gate area. And then we have another office in the East Trail with Dr. Drew Chapman. So it's the 3 of us in the practice, and been enjoying it since then. So.
Before we get to the diabetic foot, can you just tell us a little bit about your specialty? Because it is an uncommon specialty, what you do. It's orthopedic foot and ankle, which we don't see very often.
Correct. So, fortunately with our profession, a lot has evolved with our training, with our education, with our background. So as I mentioned earlier, I've had 3 years of residency training, and then I've pursued an extra year of fellowship. And during this fellowship year, I've even trained with different surgeons, even overseas, to learn different crafts and different techniques and different surgeries. We right now, as far as our specialty is concerned, and even within our practice, we're able to do multifaceted approach with foot and ankle surgery. Anything that has to do with routine checkups, to reconstructive foot surgery, to trauma of the foot and ankle, to limb salvage procedures. So we've evolved quite a bit over the last few years, unfortunately, and this has to go, credit goes to our training and our education and the people who are dedicated to continue with this training, for sure.
So there are 3 of you here, and when I interviewed Kevin Lamb, your partner, he said there are a limited number of people in the United States that do what you all do.
Correct.
So let's talk about the diabetic foot.
Sure. So the diabetic foot is always a topic that I'm very passionate about. One of the reasons why I got into doing what I do today. When I was a resident in training, one of my mentors was an orthopedic surgeon. He told me, if you figure out the diabetic foot, you could solve a lot of medical problems. I didn't really appreciate this concept until I got into practice myself, and I got to deal with this on a daily basis. And in fact, my fellowship was geared towards managing complicated diabetic feet. Diabetic foot, it's right now, I want to kind of emphasize it. Right now, November is Diabetes Awareness Month, and millions of Americans are affected by diabetes each year. Type 1 or type 2. And we see the manifestations of the diabetes on multi-systems. Their circulation, we see it affecting their nerves, we're seeing it affecting their vision, kidneys. As we already know, it's a multifaceted, multi-system approach, and we see these manifestations in the foot and ankle quite often. And when we see these manifestations in the foot and ankle, we often see them, unfortunately, at a time where it's too late or the damage has been done, be it an ulcer, be it an infection, or be it a complete collapse of the foot. We looked into some more data, and we found that the rate, or the prognosis, I should say, or I say mortality, more accurately, mortality of patients with diabetic feet statistically is much worse 5 years out, 10 years out than patients with certain types of cancers, including prostate cancer, which to me was shocking because you wouldn't imagine, a small cut or a small leg, but we look at the whole big picture approach and realize this is very important. Patients with amputations, below the knee amputations and above the knee amputations, we know that there is a increased cardiac demand on those patients, and thus there is a likelihood for higher mortality rates 5 years and 10 years. And this is data that's been published and documented. So that adds more reason and more demand, if I may, for limb salvage, and especially with the diabetic. And again, I will start off my talks with even discussions about this, about the ugly side of it, unfortunately. But there's good news in all this, that we can prevent some of these things with proper management. We can detect a lot of these problems early on, and with proper checkpoints, hopefully we could get the patients to a point where they can function and prevent progression of these complications, unfortunately.
That is a pretty impressive statistic,
Yeah.
about 5-year survival rate of diabetes. And I know that many patients don't fully understand how significant it is for their blood sugar to be normal and their weight to be normal, and so this is kind of scary.
It is, and I always approach this from the perspective that I'm not trying to, make things be, give everything kind of in a pessimistic view, but it's more of a reality. So we have to understand it, appreciate it, and be more proactive with how we could manage this. So I always start off by saying the physical examination is of utmost importance, and physical examination, not on my part, not on your part as a primary care physician as well. It's really on the part of the patient, as they have to check their feet. Grab a mirror if you don't have anybody to check your feet. Look for any cuts or corns or scratches or anything that could look remotely suspicious. Even your toenails. Check for thickness, check for drainage, if it's ingrown, if it's not ingrown. An ingrown nail can cause infection severe enough to be in the bone. And I'll never forget this. When I was a resident, I had one of my first cases that I've taken care of from the ER was a patient that had originally an ingrown nail and ended up with a below the knee amputation from complications of diabetes and complications of vascular disease and so on and so forth. But I'm not using this as a standard for every situation, but it can. This is a serious enough problem that needs to be managed.
It always amazes me when a patient comes in and they have an ulcer in the bottom of their foot, 2 centimeters in diameter, and they didn't even know it was there.
Correct.
But we're going to take a short break and talk more about the diabetic foot so we can learn more, so this hopefully never happens again. We'll be right back.
Thinking of buying a home located in a golf course community in the Naples, Marco, Bonita, or Estero, Florida? Here is what Mark Lai, former PGA winner, says about Realtor Michael York of the York Real Estate Group of Downing Fry Realty.
Hi, I'm Mark Lai. If you have any real estate needs in Naples, Florida, the one company to contact is the York Real Estate Group. Also, if you want a golf course property to invest in, Michael York of the York Real Estate Group is the guy to contact. Michael knows every golf course in Naples. I will tell you this, he's been in the golf business for a long time. He's played all the great golf courses down here, and he is an outstanding realtor. I've known him for quite some time, and he's an honest, he's got a lot of integrity, and he very much knows his stuff on all the different clubs here in Naples. So the York Real Estate Group is a great place to start. So if you have any time or anybody that wants to visit down here in Naples and look at the options out there, please contact the York Real Estate Group.
Welcome back to Dialogue with the Doctor. We're speaking with Dr. Ramy Fahim, a foot and ankle surgeon, specialist I might say, and we're talking about the diabetic foot. And we've learned a lot already about how serious things can go south in a short period of time. So prevention is the key. So we'll pick up where we left off.
Thank you, Dr. Lee. So we were talking about different ways we could detect, potential problems and when we need to be seen even as diabetic patients. Because as we mentioned earlier, diabetes does affect multiple systems. And one aspect of it, as it relates to the foot and ankle, is neuropathy. And we hear a lot about patients that have, and what is neuropathy, first of all? Neuropathy is a disease process where the nerves, in the peripheral nerves in the hands and the feet, especially in the feet, would start to die off. And in doing so, some patients experience what we call numbness. Others experience severe burning and pain. The pain is significant enough where a lot of patients find themselves needing medications and sleep medications just to help them get by. It's a very serious condition, and unfortunately, there isn't a lot of treatment that is offered for management of neuropathy to date. Medically, right now, what we do, which is really almost the standard, is essentially treating the symptoms. We use medications that could help calm down the symptoms of the burning, but don't necessarily reverse the process. Now, we found out quickly that there are medications also that can help, specifically vitamin supplements like vitamin B. Specific vitamin B type supplements can actually potentially reverse the effect of it if it's caught early on.
With vitamin
B.
Okay.
To be more accurate with this, the way I describe neuropathy to a lot of my patients is almost as if you picture a wire, that hooks up, from the phone to the electric outlet. That wire has different components, and the central part of the component of the wire is the part that actually conducts electricity or transfers electricity, but the outer layer, the insulating layer, protects it. Nerve anatomy is exactly the same way too. There's only one central component that transmits the information, and there's outer proteins and things of that nature that protects it. So neuropathy can be staged, as we know, and with diabetic patients, if we do the proper workup and find out how bad the damage is, we could potentially help them with their symptoms as far as pain-wise. And like I said, in some situations, we can also help them with proper and appropriate vitamin supplementation. Now, there's a third class of patients that can benefit from surgical intervention as well too. Surgical intervention for neuropathy is something that's been pioneered really by Dr. Dellon out of Johns Hopkins University. He's a plastic surgeon that really led the way with a procedure for nerve releases to help with neuropathy. And it's indicated really for patients with diabetic neuropathy, chemotherapy-induced neuropathy, and traumatic neuropathy. So what this procedure entails, and I emphasize this is a procedure that really has a small window of indications, a small window of patients actually qualify for this procedure. But for the right patient, given that they fit this criteria, we can potentially reverse the neuropathy symptoms. Not so much reverse the numbness, but reverse the pain. And what this essentially entails is releasing adhesions from the nerve around the knee, around the ankle, and on top of the foot. We call it a triple nerve release, or named it after him, the Dellin procedure.
Is it that it has to be done, you said at the right time, it has to be caught early?
So statistically, if patients have been diagnosed with neuropathy within the first 5 years, we find that their outcomes are much better with a procedure like that versus a patient that's being looked at 10 years out, 10 years with neuropathy or 20 years with neuropathy. Statistically, the patients that have a 5-year window do respond better. As is the case with most nerve release procedures or patients that have any sort of nerve entrapment pathology. So we find that if they're caught early, they tend to respond a little better.
So do you see, is it that you see the patients that aren't responding to medicine?
Correct. So one of the indications, I always tell them that if, I like to start off with something conservative first, say, okay, let's see how we do with the medication. Provided we've had the workup and we've had nerve conduction studies, and in some cases even small fiber biopsies could actually tell us how bad the damage is with the nerve. And we feel that if this is something that a patient could benefit from medications, certain types of medications to help with the symptoms, we could maintain that. And even with the vitamin supplementation, if they're not responding, even with higher doses, then nerve release becomes a realistic option on the table. And like I said, in the right patients, they tend to do very well.
Well, that's interesting. I don't hear surgeons talk much about medical therapy, but you're actually doing this as well.
Correct. I try to really, promote the, appropriate, full workup for the patients. Because like I said, the surgical management of it really has a small window. There's only a small window of patients that really fit that criteria. And one of the criteria really is to make sure that they go through in the medical management and see how they respond. So that's certainly something that's very important.
So what else will we talk about tonight about the diabetic foot?
So one other manifestation other than the neuropathy is peripheral vascular disease. So peripheral vascular disease is essentially a disease that affects the circulation going to the toes or going to the feet. This is something that we see in non-diabetics, and was something that we certainly see even more amplified in patients with diabetes. Unfortunately, with patients with diabetes, when they have peripheral vascular disease, the consequences are much more drastic. Statistically, patients that have peripheral vascular disease or peripheral arterial disease, which affects the arteries going to the feet, would have a higher likelihood of potential for mortality and potential for limb loss, especially in the face of infection. So when we manage patients with peripheral vascular disease, I always emphasize to my patients the best way we could catch this is doing what we call arterial Doppler studies. Those are non-invasive studies, can be done in the hospital, can be done in a lot of offices, where essentially we are checking blood pressure increments between different segments of the leg, and this would give us a prognosis as far as what is going on with the circulation if there is potential for blockage. And at that point, if we feel that there is a potential for blockage, the appropriate course of action will be, given that the patient has symptoms, of course, or an ulcer or anything of that nature, the appropriate next course of action will be vascular surgery consultation. And this day and age, what vascular surgeons can do is absolutely amazing. We find that I work closely with quite a few vascular surgeons here in town, and you look at even being someone who operates at the hospital, I look at the board every morning. You see less and less open procedures, and more what we call endovascular procedures, which is quite amazing. I mean, it's really revolutionized the way we save limbs.
Where you just put the catheter in.
Exactly. We put the catheter in and you inject a dye, and you could either stent an artery or do what we call a balloon angioplasty and open up an artery. So patients, with the right vascular intervention, as simple as that, if you don't have enough blood flow, you're never going to heal an ulcer. You're never going to heal an incision. You're not going to heal your symptoms in general. So having the appropriate workup or appropriate team with a vascular surgeon or vascular specialist that could actually do this work is absolutely crucial.
So this is the same vascular disease that blocks the arteries on the heart and
Correct.
causes heart attacks, and blocks the arteries
Absolutely.
to the brain and
It's this-
causes a stroke. It's
Absolutely.
the
Same
thing.
disease process, but it
Right.
also affects the peripheries.
You're an excellent teacher. We're going to take a small break and come back, and you're going to teach us more. I like listening.
No
We'll be
problem.
right back.
Thinking of buying or selling a home in Naples, Marco, Bonita, or Estero, Florida? Think of the most experienced York Real Estate Group associated with the #1 brokerage in Naples, Downing Fry Realty, which produced $1.9 billion in sales in 2014, controlling 43% of all transactions in Naples. Jim, Michael, and Morgan York make up the York Real Estate Group of Downing Fry Realty. With over $250 million in sales transactions, they can offer you the expertise and trust you want and need in a realtor. Call them today at 239-273-6727 or visit their website, www.naplesyorkrealestate.com.
Welcome back to Dialogue with the Doctor. We're here with Dr. Ramy Fahim, a foot and ankle surgeon, specialist, subspecialist actually. We're talking about the diabetic foot and ankle. We just got finished talking about nerve issues, and now we're into vascular issues.
Indeed. And we were just talking about the manifestations of vascular disease and what we're able to do to address the vascular issues. So certainly, and as far as the diabetic foot, and realizing that, if we're looking at an ulcer, for example, or a patient that has an open wound or an infection, you look at the manifestation as a whole. So this vascular disease that we speak of, you mentioned that, okay, this is the same disease process that also affects the heart and potentially the vessels that go to our brain, with strokes, and the peripheral circulation. Another segment of this is also our kidneys. And patients with, and not just kidneys and vision. So this is something that also affects. And why is this important from a foot and ankle point of view? Essentially because we found that patients that have renal disease or kidney problems in general have poor protoplasm, so therefore poor healing potential. Therefore adds another challenge to the dynamic of trying to, saving their limbs. And that's why with what we can do now for try to save these wounds has drastically improved. Today, we're able to use a lot of synthetic grafts that can help with speed up the wound healing. We've even incorporated amniotic tissue technology, stem cells, and actually help wound healing, which is something that wasn't done before. This is something that really has been increasingly becoming more and more popular, even in literature over the last 3 to 5 years especially. And now we're seeing also more and more push for doing things like platelet-rich plasma injections, which again involves taking blood from the body, spinning it in a centrifuge, and isolating platelet cells to try to stimulate a healing pattern or an inflammatory response, if I may, to try to stimulate this healing. And another segment of all this is really just understanding the anatomy of the foot and the reconstruction of the foot. So a lot of times when we see patients with these ulcers, an ulcer in the foot is much more significant than anywhere else in the body because the architecture of the foot is always involved, especially in diabetic patients. There's a disease process we call Charcot. It's named after a French surgeon. It's spelled out C-H-A-R-C-O-T. This disease process is a neurological and a vascular process where it involves repetitive micro-trauma of the foot to the point that joints are dislocating. And when joints are dislocating, the anatomy is definitely altered. The pressure points in the plantar foot is altered. Therefore, patients develop ulcers. I can't tell you how many times patients show up to, even ERs or colleagues' offices and practices, and they don't get a foot X-ray. And that's usually, that should be a knee-jerk response as far as seeing something like that, because there's usually a reason for that ulcer. It's not just poor healing, like we mentioned earlier, the circulation, the renal issues, the neuropathy certainly play a huge role in this. But the morphology and the changes and the anatomy is what dictates how these changes are manifested. So when I see a patient like that, the goal really is not just to offload, but what can we do even surgically to save this? In my opinion, a patient with a Charcot foot deformity, a dislocated joint, that's a surgical indication. We could help this patient. We could realign the joints where they need to be until the infection is gone, get this infection out of the bone, if it is indeed in the bone, manage the patient with a team effort, involving obviously the primary care physician with the glycemic control, manage the renal issues with the right workup, if nephrology is indicated, or nephrology consultation is indicated, vascular workup like we mentioned, and certainly infectious diseases if there is deep tissue involvement. So in doing so, with this multi-team approach, we could actually, and we do actually save limbs, not just here in the community, but we save limbs also on a national scale. Saving limbs, like I said, is the main goal for all this, and not just from a surgical point of view, but also from patients' quality of life point of view, moving forward. Now, I just kind of put things in perspective here as far as the saving limbs, but ultimately, I go back to saying what we said earlier. The key to preventing all this is really checkups, appropriate checkups. Make sure that you get your blood sugar under control, follow with your doctor, have your feet checked routinely. And if you're having your feet checked, make sure, and you are diabetic and you have neuropathy and you have toe contractures or any hint of issue or calluses or potential for skin breakdown, make sure that you have your feet checked and make sure you get fitted for diabetic shoes. Make sure that you get fitted for diabetic socks. Make sure that there's somebody managing you, not just from a medical point of view, but also from a foot and ankle point of view. The goal here is to try to prevent needing anything invasive or aggressive, and if that happens to be a situation, the good news is that we can manage those problems. We can manage complicated patients, complicated wounds, or complicated deformities with the right workup and the right team.
Well, this is much more complicated than most people realize. You get the nerves, the blood vessels, then the bones, and it's a watershed effect. But we really appreciate you coming
thank you
on our
Ramy.
show. And I've learned quite a bit, and I'm sure our viewers have learned quite a bit too. And you sound like somebody worth seeing when they have a problem.
I appreciate that. Thank you.
Thanks for coming.
Thank you.
We should have you back.
I appreciate that. Thank you.